So she came all the way from Bombay. Thank you for coming. And the title will be Correlation between Peritoneal Carcinomatosis Index and Postoperative Pain after Cytodestructive Surgeries and Hypothermic Intraperitoneal Chemotherapy. It's a retrospective cohort study.
Yeah. Good morning, everyone. So this is about my topic. So I'll be using terminologies CRS for cytoreductive surgery and HIPEC for hypothermic intraperitoneal chemotherapy, which is given after the CRS is done. So peritoneal cancers are now considered as loco-regional extension of the primary tumors instead of advanced cancer. So initially we used to label it as an advanced and go to palliative care, but now we do operate them because of the improved survival. So it includes not only the nociceptive pain, which is there because of the surgical trauma in most of the patients, but also a neuropathic pain due to heated chemotherapy. There are abnormal ectopic neural activities from nerve damage. Patient might have a preoperative pain, anxiety because of the major supramajor surgery, and all in all, it will add to the postoperative pain. So this is a slide about effect of intravenous chemotherapy on the pain of a patient. So basically, the chemotherapeutic agents act also on the DRG, causing neuronopathy, gangliopathy, and acts on the peripheral nervous system, causing peripheral neuropathy, axonopathy. So baseline neurological inflammation is there, along with increase in the pro-inflammatory chemokines, cytokines, and increase in the receptors. Now this agent is not given IV during the surgery. After the surgery, when there are raw surfaces, there are raw nerve endings there, the heated chemotherapeutic agent is put into the abdomen, and hence we expect an exaggerated pain effect in this state of patients. Now this is the PCI scoring that we do. Higher the PCI, the peritoneal carcinomatosis index, higher will be the disease load, higher will be the surgical resection and the surgical time, which will impact the postoperative analgesia. So this is kind of a scoring system depending on the tumor size and the quadrants used. PCI score ranges between 0 to 39. So our hypothesis is extensive dissection, prolonged duration of surgery. The surgeries go around 12 to 18 hours, especially the mesotheliomas. Associated with higher PCI, use of heated chemotherapy will lead to a higher postoperative pain and increased need of postoperative analgesics. Primary outcome, correlation of the PCI scoring and the worst pain scores in postoperative period within 96 hours of surgery. Secondary outcomes are the different analgesic modalities used, the pain scores at rest and movement, the incidence of coagulopathy, referrals to the APS, acute pain service pain clinic after this period up to discharge, and reference to chronic pain clinic within 6 months after discharge. After the IEC approval, the retrospective review of the patients were done from 24th December 2015 to 26th February 2021, and we used all the database, the CRS HIPEC database, the APS database, and the EMR, the electronic medical records in all these patients. We include all the patients above 18 years of age who underwent CRS, and exclusion criteria was absolute unavailability of the data from the database. Statistically, analysis was done as routine. We used a chi-square Pearson test or a Fisher-Exact test to identify the significance. So now the results add discussion. So we included 150 patients, out of which one patient was minor, so he was excluded. We analyzed 149. Out of 149, 12 patients were ventilated for more than 4 days. From 132 patients, no pain data was available for 20 patients, so we had 112 patients. So we have a demographic data of all this, but pain data we had of 112 patients. So more number of females were operated, there was no gender correlation, maximum patients were ASA 1 and the mean age group was 47. So correlation between gender and pain score as discussed was statistically insignificant. Primary diagnosis, so most of our patients were from primary colonic cancers. which were followed by the gastric cancers and which were followed by the dreaded peritoneal mesothelial cancers. Modalities of analgesia used? Yes, absolutely. Epidural was used in most of our patients. Truncal was used only in 1% of patients, where epidural was completely contraindicated because of coagulopathy. And PCA was used in 6%, but epidural and PCA was used in 14% of patients, probably because epidural was not giving a good coverage, or epidural was not used because of hypotension and so added PCA benefit was given to the patient. Worst pain scores, so the mean worst pain scores was around 4 on day 1 and day 2, and rest of the days it was mild pain scores. Correlation of worst pain scores with the PCI. The correlation between PCI score and pain score was statistically significant only on day 2. Rest of the days there was no any significance. Mean PCI score was 12. So as per Patrick Tickey, the mean time to the onset of sustained uninterrupted 5 sequential postoperative pain relief is around 31.5 hours. And the interquartile range is up to 54.2 hours. So by day 3 or day 4, minimal number of patients experience moderate to severe pain. In our case, the mean ventilatory support was 3 days. So these patients had a continued opioid infusion. Hence, probably the pain scores were not very severe, they were moderate, and into moderate range, the mean was 4. Now, this is the most important thing which we got in our study, epidural correlation with the worst pain scores. As you can see, the amount of patients who had a moderate pain was 43% at rest and 68% on movement. So one box will not fit to all patients. The doors are open for concomitant use of PCEA, truncal, additional truncal blocks and additional IV PCA. So here, Dr. Smith et al. Had studied a post-operative epidural analgesia in the same set of patients, the CRS HIPEC, and they found that it worked beautifully. They didn't need additional analgesia, no pain scores were obtained. Our findings were not consistent with it, but we could not find data of co-analgesics in this set of patients, like paracetamol and diclofenac, which might not be adequately used because of the contraindications like bleeding and coagulopathy and deranged LFTs. Having said this, if we can't use it optimally, we definitely need additional co-analgesic or other modalities of analgesia. IVPC and average worst pain scores. So this was a small group of patients, but still we can see that in IVPC group 2, we had a large amount of patients with a moderate pain score. So again, only IVPCA is not sufficient, though it is not statistically significant, maybe because of the small group of patients. So now correlation of coagulopathy with PCI, 34.7% of patients developed coagulopathy, and we found a statistically significance in correlation with the severity of the PCI and a coagulopathy. But there was no correlation of the coagulopathy with the worst pain scores at rest or during movement. So this is blue is no coagulopathy and the red is coagulopathic. We didn't see any epidural complications, the major epidural complications, but 6% of our patients required blood products for the epidural catheter removal. So we suggest to do a coagulation profile before removal of the epidural in this set of patients. Now correlation of duration of surgery with worst pain scores, we can see this graph. So we didn't find any statistically significant correlation, but I would say that if you see this graph in the severe range, definitely the severe pain scores correlated with the duration of the surgery. But however, for the moderate one, the duration of surgery was not much, so there was no any statistically significant correlation. In our set of patients, 6 patients had a preoperative pain, but the pain scores on movement after surgery was not statistically significant, neither was the PCI score. Now, there are many studies which have found out that preoperative pain causes lot of, increases the opioid requirement after the surgery. In our set of patients, it was not, probably because these patients received weak opioids, and again the tumor was removed, the source was removed, so there was no correlation that was found. We had a re-referral of only 5 patients, saying that the severe pain was not there much in this set of patients. We required only one rescue intervention with the ketamine for one patient, wherein the PCI score also was high, and absolutely, definitely the pain scores on movement were very high. Chronic pain, we had only 6 patients with a chronic pain, and I think here the role comes of epidural, which has stopped the inflammatory mediators, prevented the central and peripheral sensitization, because of which the acute has not progressed into the chronic. In this 6 set of patients, 4 patients had a new onset pain because probably the tumor was advanced, and 2 patients had a pain which was continued from acute to chronic. So my conclusion, the current study shows a positive correlation in severity of PCI score and worst pain score on day 2. No correlation in overall pain scores. Prospective trials will be required to confirm the findings. Epidural is a mainstay of these surgeries. Having said that, it should not be a sole analgesic modality because it will be insufficient as per the study. Increase in PCI increases the coagulopathy. Limitations, however, is a retrospective nature of the study being done in a very large amount of patients, the largest database that we have for pain scores and high tech till now. Yeah, that's all. Thank you very much.
Yes.
Hello, yeah, again, excellent presentation, and it looks like you put so much effort to collect data and present this. Excellent. Can I ask how many of these were laparoscopic procedures and how many of them were open?
So none of them were the laparoscopic procedures, all of them were open procedures.
Okay.
Yeah.
Okay. And has any of these patients received rectal sheath block or local anesthetic infiltration or anything at all?
Only 2 patients received truncal blocks. Those were subcostal tab blocks.
Right.
Yeah, because of the contraindication for the epidurals. And this stage of patients, we don't do a laparoscopy because it is as good as doing an abdominectomy is what we say. Large amount of things are removed.
Okay, thank you.
At which level your epidurals were inserted?
So all our epidurals are incision congruent. So it is around it is at T9, T10 with a clinical correlation.
How do you explain that the analgesia were insufficient?
Analgesia was insufficient.
You said epidural solar anesthesia modality is insufficient.
Yeah, that was because if we say the epidural is working, which we do a band checking at the end of after the surgery when the patient is awake and alert. So we wait for a complete loss of sensation in those segments, or at least a decrease, 50% decrease in sensation. So in those cases, if some segments are lost or if segments are not covered, then we take over the co-analgesics, which takes over the role of insufficient epidural. But in this patients, if you have seen that moderate pain scores for these patients were around 48% at rest, which is a high number if your epidural is covering the whole abdomen. And 68% is again a very high amount of number with a movement. So our aim is to target it to a mild one, especially with a working epidural. So I feel, now again we have a limitation because we don't have a co-analgesics that were used for such patients. How much paracetamol was gone, how much diclofenac, have they received gabapentin or no. So generally these sets of patients don't take gabapentin or pregabalin because it's a tablet form, and these are all GI operated, so they are generally NBM. But we don't have a data of paracetamol or diclofenac.
Why you want to add gabapentin and pregabalin?
So now the recent study had shown that there are no significance in pregabalin and gabapentin, but we still feel that thoracic patients do get gabapentin or pregabalin if the pain score is on a moderate range. These patients had a chemotherapy, so we expected a neuropathic pain component also. So I guess these pregabalin and gabapentin should work. We'll need further studies to prove it.
Yes. Okay. Yes, ma'am.
Thank you much for excellent presentation. Just a question about the epidural itself. Did you face any physical damage of the epidural? Usually the patient is maybe 12 hours surgery, supine all the time. Usually there will be heating mattress and intraperitoneal chemotherapy. We had about 20 cases in my hospital, and some of them we found the catheter, and it was well-known brands affected physically, so you may face obstruction because with the heating it became elongated, and so almost some physical damage from the catheter itself. At the end of surgery, for some cases we need to resize the epidural again before waking up the patient. Did you face any of this?
No. So not for the high-tech patients that we have faced the kinking problem. The mattresses in our set is not a table mattress, it's an overhead mattress that we have, that's one. Recently, we have changed over from Cortex to another epidural sets. In those patients, we had kinking problems, but not during these patients.
Thank you.
Yeah, thanks. Any more questions, please?
Just about the case, how many chemo agents you have used?
Yeah.
And what temperature? Is it 43 single agent or more?
No, it's 41 in our set, and we have used adriamycin, mitomycin, and cisplatin. The duration of high-tech remains standard. It is 60 to 90 minutes, unless it is generally 90 minutes, unless the patient becomes more hemodynamically unstable, when we stop at
And
early.
temperature?
Temperature is 41, sir.
41.
41. Yeah.
Okay, thank you.
Thank you very much.
Okay, great. This is the end of the session. Coffee break, and we resume in 15-20 minutes.